Can you believe it? You're at the end of the course. So I want to welcome you to this final module 14, Quality Control and Quality Assurance. The results obtained from laboratory analyses are used to diagnose, prescribe treatment, and/or monitor the health or progress of the patient. Quality control is the heart of determining whether a specimen analyzer may be used to test patient samples. Just because an analyzer produces a result does not mean it's correct. It must be accurate and precise. Personnel must not be allowed to run automated tests until they have a solid foundation in the basics of quality control. So we put our samples on the analyzer, then magic happens and results are produced. You can't just say that because the machine produced this result that everything's fine in the world. We have to do a lot of stuff before those samples go on to the analyzer. So the purposes of this unit is I want you to focus on becoming familiar with the terminology used for quality control and quality assurance. You will actually practice, analyze, and determine acceptability of QC results in each of your MLT courses as well as your clinical rotations. Every laboratory must have a comprehensive quality control program. And the terms used, quality control we call QC, quality assurance is QA, and total quality management is TQM. These elements may include the current procedure manual. The first thing you'll do, whether you're in student lab or in the clinical or your first job, is to sit down and review the procedure manual. It will include documentation, meaning these are the procedures and the steps that we will use to run this QC program. Personnel standards, what are the minimum educational qualifications in order to be able to perform this specific task. The manual may also have the fire and safety program, use of appropriate standards and controls, which are the samples that are used to determine whether our analyzers are functioning properly, and external proficiency testing. Quality control is defined as a statistical process used to monitor and evaluate the analytical process that produces patient results. It is one of the most important aspects of laboratory testing, as it will ensure both the precision and accuracy of patient test results. So the purpose is to detect and resolve problems before potentially inaccurate patient results are reported out. The type of quality control required will be determined by the type of test that's being performed. So again, this is done prior to testing any patient sample, because if your QC fails, then you need to take steps to resolve that failure prior to testing patient samples. The first type of test we're going to talk about is the qualitative test. This is a test in which the results are either positive or negative, like a pregnancy test. We usually refer to these as kit tests. All the components are within the kit, and prior to testing, we do have to perform QC for the kit. So what we want to do is run the external controls. These are provided by the manufacturer with a sample that is a known positive and a known negative. And first thing you do when you open a kit is you run those external controls. The test must give the expected results. If the expected results are not obtained, you can repeat it, but in kit tests they may only provide enough QC material to run it once. But if after testing the test results are still not valid, the kit must not be used and the manufacturer must be notified. Because if your positive QC sample is not giving a positive result, then you will fail to detect that particular element. For example, we're doing a flu test, and we may get a false negative, not because the patient doesn't have the flu, but because for some reason the kit is not working as expected. So if you know the flu, if you're diagnosed within 48 hours, you can get on Tamiflu, which shortens the run of the disease. So it's very important that if these external controls do not give accurate results, that you cannot use that kit. Usually we have backup kits. We order more than one kit at a time, especially during flu season. Then there's another type of control in the kit test, which is called the internal positive and negative controls. And these must give expected results. And we'll talk about that on the next slide. Once the kit passes QC, it may be used. And what I have my staff do at my doctor's office is as soon as the kit comes in, let's go ahead and do the QC so that once we run out of the current kit, we have this backup kit that is already ready to go. Also, if there's a problem with the QC, we can call the manufacturer and get a replacement. So here's a qualitative pregnancy test, and this isn't like the one that you buy at the grocery store. This is more involved. Almost all kit tests have the same interpretation method. The only difference will be the substance we're testing for. In pregnancy, it's HCG. In flu, it's the virus, the flu virus. So each one has a different target, but the methodology is pretty much the same. The control line, as you can see in the picture below, once you run the test, this lets you know that everything worked properly and that if the patient had what we're looking for, we can trust it because this control line is positive. The background must remain clear. If it colorizes to the extent that we can't read the results, then the test is invalid. So the negative control is the background. So here in the middle, you see positive results. There's a very, very faint line, which is why we must read these tests under very good lighting, because any type of a line at all is a positive result for the patient. These are invalid test results. There is no control line, so the test is invalid. This has a result line, a positive at the result line, but the control line is negative. If the control line doesn't work, then the test is invalid and you would need to repeat it. The next type of test that we do in the lab is called semi-quantitative, which gives an approximate result. The most frequently performed semi-quantitative test is the urine dipstick. Some of the chemicals will be read as a semi-quantitative amount. After we dip the strip in urine and we follow the procedures of the manufacturer and we blot, we then note color changes at specific times. And then the color of the pad is matched to a result. So if it says read the result at 15 seconds, you mentally look. You don't have to record it at that moment in time, but then you note that it's either normal or what the semi-quantitative amount is. There's some that are read at 15, 30 seconds, 1 minute, 2 minutes. So you really have to be on your game if you're doing these manually. The result is not a specific quantity. For example, on a chemistry analyzer, we have 298 milligrams per deciliter. But it may have an approximation that this equals approximately 300 milligrams per deciliter. Two controls are run, a normal and an abnormal, which must give the expected values. So the normal would be normal for everything. The abnormal would be abnormal for everything. Also, when you're in training, it gives you a good idea of what a positive or abnormal result looks like. The next slide illustrates the results which may be reported out. So on the left-hand side, it shows you the different levels of positivity for these 4 analytes. And then on the right, we see this has been dipped in a urine, and we compare it at the appropriate times with the colors on the bottle which have the results, and that's what we report out. The final type of test is the quantitative test, and the quantitative test will give an exact number which indicates the concentration of an analyte in a specimen. The results are obtained from a sophisticated analyzer which range in size based on the number of test samples which can be analyzed in a given time frame. For example, in a very small doctor's lab, you may have the baby analyzer, Whereas in a 300, 500 bed hospital, you're going to have the granddaddy analyzer, which is huge and can run hundreds of samples per hour. The larger the analyzer, the higher the number of samples which can be tested per hour. And because these are expensive, you only want to buy that type of analyzer that suits the quantity of testing you perform. So control solutions are used daily to validate that the analyzer can be used for patient testing. A control is a solution that contains the same constituents as those being analyzed in the patient sample. The manufacturer has analyzed each lot of control material for a variety of test components, as well as set the range of assay values for each component that's provided. So a control is not a positive or negative. It's not a semi-quantitative result. It will say this for protein, the result will be 5 to 15 milligrams per deciliter. If your value for the normal control falls within that range, yay, then you are in control. Depending upon the analyzer, there may be up to 3 levels of controls. High is the abnormal control, in which the results are above the normal range for each of the test analytes. Normal is the results that are falling within the normal range. And low is the abnormal control, in which the results are below the normal range for the test analyte. Because high levels or low levels of these analytes in a patient may indicate something's going on, something's wrong with the patient. So when do we run the controls? They're always analyzed prior to using the analyzer for patient samples. And this is done to determine if the analyzer is functioning properly and if it will provide accurate results on patient samples. In hospital labs, which run 24 hours a day, 7 days a week, the controls may be run at the beginning of every shift. The results of the controls are compared with the manufacturer's range of values, and each control value must fall within the manufacturer's values. They say, well, that low control, it says the bottom number is 15. I got 14. That's close enough. No, absolutely not. And fortunately, now that we have computers, these are also analyzed by the analyzer itself and will not allow you to proceed to patient sample testing until the controls are within range. And it's not that you run the control over and over and over and over. It's you follow the process. So the following table shows an example of expected results for the 3 levels of controls. And each analyte will have its own value. So we'll have protein, glucose, bilirubin, etc. Every analyte will be tested and have its own range. So we've talked all about the different types of controls and the fact that controls must be run first, and patient samples cannot be run if the controls do not come in. Proficiency testing determines the performance of individual laboratories for specific tests or measurements and is used to monitor the laboratory's overall continuing performance. Lab proficiency testing is more than an internal quality control measure, as it provides an important comparison and objective assessment of lab staff competencies, specimen handling, equipment functionality, and results reporting. So it's a measure of all of these different elements in patient testing. A lab will contract with a proficiency testing company which sends unknown samples to all of their affiliated laboratories 3 times a year. And this is important because if you can shut me down due to failed proficiency testing, I want to make sure that the results that you have as a PT company are accurate. So all the labs test these samples, all the labs send in their results, and if there is an outlier, if all the labs fail a certain component of the PT testing, maybe the sample was off. So that has to be taken into consideration. When we get the samples, we are to treat the sample like any other patient sample when testing. And there are a lot of hospitals that are, for example, Ascension has multiple hospitals. So we contract with the same provider. You cannot call up your sister lab and say, hey, I got these results. What did you get? Because then you may want to repeat your testing. And who's to know that your sister hospital didn't get the wrong results? So again, we want to treat these just like any other patient sample and report out the results that we obtained the first time testing. You don't do repeat testing. I don't test a regular sample 3 times. Now, unless your protocol calls for it, let's say that you get a highly unusual value, the protocol in most labs is repeat. So you have to follow your lab's guidelines. The results, again, are graded by the company, and if a laboratory has any unsuccessful results, it's expected that the lab investigates the reason for the disagreement and implement corrective action. Governmental regulations requires participation in at least 3 PT events per year, each with 5 specimens. So you don't just get 1 blood glucose sample. You'll get 5 samples because testing 1 sample, we don't know if those results may be a fluke, but having 5 separate individual samples, each sample different, so we expect that some of the samples are going to be normal, some of the samples are going to be abnormal. And it's done for every subspecialty or specialty. Mycobacteriology requires 2 events per year. CLIA, if you remember CLIA, remember we were talking about governmental agencies, this is the Clinical Laboratory Improvement Act, regulates how PT providers score PT challenges for these analytes and mandates that all labs that fail to achieve satisfactory scores be reported to the Centers for Medicare and Medicaid Services. And they must initiate corrective action for issues related to poor PT performance. This is a huge deal. PT is mandatory, and if you fail, then you could have severe consequences. And CMS clarification and communication on the requirements have been that you met to resume testing after a ceased testing period. The CAP is ensuring enforcement of an additional consequence. The laboratory must cease testing for a full 6 months after a ceased testing for a regulated analyte. So if there's problems or issues, you may not be able to perform the testing. So again, we have all these different layers, and the whole purpose of these layers is for the health and safety of our patients. So we've done our QC, and we have all these numbers, and we have all this data. What are we going to do with it? Well, statistical analysis of that data is the most important component of quality control. Fortunately for you, the statistics needed for control material are performed by the manufacturer, and many manufacturers have a way for the users to download them onto their analyzer for each new lot number of control used. Back in the dinosaur days, we had to enter the data individually into the computer. So it's really nice when you got that new set of that new lot number, rather than have to put in the values for each analyte, you can just download and it integrates into your computer system. Techs nowadays are so spoiled when it comes to this type of information. Although you will learn a variety of statistical terms and formulas, the 2 most frequently used in the laboratory are the mean and the standard deviation. Let's dust off the cobwebs from your math from K through 12 when you're first introduced to this material. What you need to know is the definitions of these and what they mean. So the mean is also known as the average. So all of the numbers for the calculation are added together, then divided by the total number. So I've given you the formula, and here's an example. The number of graduates for the last 5 years are this. So what is the average? So you put the numbers on the top and add them all together. What are the total number of numbers? It's 5. And so then we end up with an average of 20.2 graduates per year. Standard deviation is a measure of how close numerical values are in relation to each other. The term precision is often used interchangeably with standard deviation. The SD is calculated for control products from the same data used to calculate the mean. So whatever data that we're using to calculate the mean for that specific control for these different analytes, those values are put into a different formula to calculate the standard deviation. So let's take a moment to talk about precision and accuracy. No laboratory measurement is perfect, and all measurements have some error associated with them. In the laboratory, we are always determining whether our analyses are precise and accurate. Accuracy, the deviation of a measurement from a standard or true value of the quantity being measured. And precision tells us how close a group of measurements are to each other. Their results may be accurate but not precise, or they may be precise or not accurate. We have to have both. So what we're going to look at is, this is an illustration which no matter what program you go into, this will be an illustration of accuracy and precision that will be used. And so when we have high precision, we have all the results that are very close to each other, but it's low accuracy because none of them hit the bullseye. Here is low precision and low accuracy because these are way out. They're not within range of each other. They're not close enough. They're all outside the middle area, which are target, and there is no accuracy. Then we have the low precision and high accuracy, where it's accurate because all the values are close to each other, but they're not close enough to the target. And then here's the example of high precision and high accuracy, where all of the results are very close together and within the prescribed limits. Is your head spinning yet? It's difficult explaining these concepts, and you may want to find additional resources that may explain it better. I would encourage you to search for a video tube on Basic QC for more explanations. And I have provided a few resources in this module, including one from my colleague. These basic concepts will be explained in detail in future MLT courses. For now, I want to focus on the terminology. Dr. James Westgard is internationally recognized as a QC expert. And what's kind of funny is his son has followed in his footsteps, and I attended a QC webinar last week. And yeah, so they are the world's, regarded as the world expert. Dr. Westgard developed the Westgard Rules, which is a set of rules used for laboratory quality control to this day. I would encourage you to bookmark his website if you are an MLT student, as it will be invaluable to you in the future, not only as an MLT student, but as an MLT practitioner. Here's his lesson on Levy-Jennings control charts, which is our next item of discussion. So I would encourage you to go there and just review this lesson. They're not very long. Now we're going to go a little bit into the analysis of data. So you will see the picture on the following slide in every procedure which explains quality control at the beginner's level. The Gaussian curve, also known as a normal frequency or distribution curve, represents the normal distribution of data. The goal in the laboratory is accuracy of results. Laboratories are required to set the minimum standards for results within plus or minus 2 standard deviations for QC for each laboratory test or analysis. What that means is if we have plus or minus 2 standard deviations, 95.5% of all results will fall within this range, which is great. So the next slide illustrates what the Gaussian curve looks like. So the classic curve has 68.2% of the results falling within plus or minus 1 standard deviation, 95.5% within plus or minus 2, and 99.7% will fall within the plus or minus 3 SD. So we've talked a bit about controls and means and standard deviations in the Gaussian curve. The Levy-Jennings chart is a graph that is hugely important in the evaluation of QC data. So what we do is the daily QC data for every control is plotted on a chart, which then gives a visual indication of how well a laboratory analysis for a specific analyte is working. The chart will always have lines indicating the mean, plus or minus 1 standard deviation, and plus or minus 2 SDs. And we want all of our results to fall within plus or minus 2 SD. So a Levy-Jennings chart is created for every analyte that we're testing for. And so, for example, a CBC may have 5, so you'll have 5 LJ charts. So let's look at this. So we have here, right here in the middle is the mean. And then here's our plus or minus 1 SD, and here's our plus or minus 2 SD. What you'll see is there's a control here that fell out of range on this date. And then this one also fell out of range. But most of them are close to each other and are within the ranges set by the manufacturer. So there's accuracy and precision. So the evaluation of data is what makes you a scientist. And that's what we are in the laboratory when we're working with our analyzers. We are scientists. With experience, evaluating these charts will become second nature to you, as they are the most frequent way QC data is evaluated in the clinical laboratory. You come in, you run your controls, they're plotted on the Levy-Jennings, and again, this is all done by the computer. You look at that. If they're not within plus or minus 2 SDs, then you need to figure out what to do next. So we're going to look at an example step by step, and the following slide will illustrate the plotting of a control. Remember, there will be a separate chart for each control, normal, abnormal, and maybe even another abnormal, and each analyte. You need to determine whether the control is valid based on whether the data falls within the plus or minus 2 SD. And then one of the most important things we look for, there's many other types of analyses, but you want to be able to identify shifts and trends, which indicate that something is going wrong with your analyzer and that you need to do some troubleshooting. So we're going to look at a Levy-Jennings chart that indicates a shift. So in the chart below, 90 is the mean. So we have 90 plus or minus 1 standard deviation, then plus or minus 2 standard deviations. A shift is defined as a sudden change of values from one level of the control chart to another. When the 6th value on one side of the mean is reached, the values are considered out of control, although they may still be within plus or minus 2 SD. So if you look, all of these values are within plus or minus 2 SD. But if you look at day 4 compared to day 5, we get this jump, which, that's okay. It can bounce around the chart. But the values never come back for a certain number of days to, a different part of the chart, a different part of SD. So even though all of these results are in, meaning they're within plus or minus 2 SD, this shift needs to be investigated and determine why we're not getting a normal LJ chart. So we just learned that a shift is when the value goes to a certain part of the chart and never comes down. The values are all, that's a shift. A trend is an uninterrupted rise or decline away from the mean. When the 6th value with the rise or decline is reached, the values are considered out of control, even though, once again, these are all within plus or minus 2 SD. So if we look at day 5, we see that it went up and then it's slowly coming down, but it's not bouncing around like we would expect a normal LJ chart chart to do. So this indicates there's a problem. So what you want to do when you have a trend is do some troubleshooting on your equipment to determine what is the cause. So the analysis of quality control is crucially important in determining whether the patient results are accurate and reportable. So we know that if QC fails, we can repeat it up to 2 additional times. And you have to follow the standard operating procedure of your particular lab as to when and how that's done. If any control result fails, then you have to perform problem solving and troubleshooting to determine the cause of the failure. Patient samples cannot be run on the analyzer until resolution is reached. If the analyzer is not functioning properly, then samples must be sent out. The health and safety of our patients is our first priority, and inaccurate lab results may result in improper diagnosis and or treatment, resulting in serious medical consequences. So I was lab director for a physician office lab. I was not on site. And so I got a call from the lab manager that something was wrong with the hematology machine. I said, okay, I'm coming in. And the long story short is QC was not in. She repeated it 3 times. The QC was up to, you can repeat it up to a total of 3 times. Well, rather than send samples out, the doctor insisted that this person, who is not an MLT, perform the analysis. So the results of this analysis were so bad, so abnormal, that the physician sent the patient to the emergency room. Well, the patient gets there, they perform the same test, and the results are normal. Now remember, the QC did not come in for our analyzer. And so what had happened was this person did not follow protocol, but the analyzer, it was not draining properly, so every result was more dilute than the previous result, which ended up with totally inaccurate results for the patient. So I just want to let you know that this has consequences. That physician's practice had to pay for that emergency room visit because it was their fault. So quality assurance, the definition of quality assurance, it involves the entire testing process. A lab's QA program must assess the effectiveness of the lab's policies and procedures, like my employee who did not follow protocols and that patient was sent to the ER. You need to identify and correct the problems before running patient samples, assure the accurate, reliable, and prompt reporting of test results, and assure the adequacy and competency of the staff. So there's all these different components that are part of the QA program. The lab must initiate corrective action when problems occur and document all quality assurance activities. In the lab, we have a saying, if it's not written down, it's not done. Well, I double-checked this. We'll prove it. Well, but I did it, but I just didn't write it down. Well, then it doesn't exist. And now you're on probation. Part of quality assurance is identifying errors. And errors or variables in the lab are identified in one of 3 types: pre-analytical, analytical, post-analytical. Failure to identify and resolve may result in dire consequences for the patient. This is a very nice illustration of the quality assurance cycle, and it pictorially shows you the difference between the pre-analytic, analytic, and post-analytic. So pre-analytical errors defined, these are errors that occur prior to specimen testing and may include variables involving the process of obtaining the specimen from order to delivery. So some examples are the coagulation tube was underfilled, which once you take phlebotomy, you'll understand this is a huge no-no because this will cause inaccurate results. For CBC, which must be drawn into a lavender top tube, is collected in a red stopper tube. If you fail to write your initials on a tube of blood, because this is a legal record, and if those initials aren't on there, I don't know who drew it, and if bad things happen to the patient because the results are inaccurate, we need to find somebody, whoever caused that problem to occur. Some samples are required to be maintained at 37, which is body temperature, and it was left at room temperature. So there's all kinds of things that occur pre-analytically that may result in inaccurate and imprecise results. Analytical errors are those that occur during actual testing of the specimen. Performance of tests in the laboratory is rigorously controlled with QC procedures in place that markedly reduce errors in the analytic phase. Differences in the methods for performing tests in different laboratories may yield slight differences in reported results or normal ranges, so check reference ranges given for the test. Examples: control values are out of range, yet patient samples were run and reported out. That's an analytical error. That's what happened to my patient. Sample result was out of range of the instrument requiring it to be diluted, no dilution performed. We have a certain range in which our analyzers are accurate, but if an analyte is very, very, very concentrated, it may exceed the capacity of our analyzer, and so what must be done, you must dilute that to get a reportable result. Post-analytical errors are those that occur with entry, manipulation, and reporting of test data. If results are written by hand or entered via a keyboard, then an entry error may occur. Errors in data transmission include relaying or hearing verbal information incorrectly. We have what's called panic values that must be reported to the nurse or the doctor immediately. And if we give the wrong result, maybe use the wrong units, then that could result in severe medical consequences to the patient. Reporting problems include exceeding the turnaround time for reporting or not notifying the appropriate healthcare provider verbally of a critical result in a timely fashion. So we've analyzed the results, so everything that has to do with getting those results reported out accurately is the post-analytical. So quality assurance, errors will occur. We are human. I can tell you stories of errors that I made, but once I recognized them because there were processes built into my system, I was able to correct those before they caused harm to the patient. The goal of the QA is to have a plan of action which includes identify and classify errors which occur, determine how that error occurred, resolve the error so hopefully it will not occur again. For example, that employee who reported out results on a sample that the QC did not come in, we need to mentor and counsel her as to why she did a bad thing so it won't happen again. And then track the resolution to ensure that it has fixed the problem. You must take this responsibility seriously, as the health and safety of patients may be at risk if the problems are not handled swiftly and properly. So in summary, quality control and quality assurance programs are essential for producing accurate and precise results on patient testing. Understanding the basics of QC, especially evaluation and troubleshooting, is a crucial part of the performance of laboratory testing. Familiarity with the terminology used will become easier as QC is addressed in future MLT courses. QA encompasses the evaluation of all aspects of laboratory testing, and identifying and classifying errors, determining the cause of these errors, finding the solution, and then evaluating the effectiveness of the solution are crucial for our patients.